We now invite Dr. RAKHI KUSUMESH for her keynote address. AIOC Cornea Award, Bihar Ophthalmological Society on miltefosine related keratitis, clinical characteristic and management.
Good morning, everyone. First of all, I would like to thank AIOS Scientific Committee for giving this AIOS Cornea Award to this paper. So I have no financial interest. So miltefosine is a phosphocholine analog originally developed as anti-malignant drug, and it was recommended by WHO as the only oral drug to treat all types of leishmaniasis since 2002. So we all know that leishmaniasis is a group of diseases caused by parasitic protozoa of genus Leishmania, and it is transmitted by sandflies. And the most common and serious form of it is Kala Azar, known as visceral leishmaniasis, and in 10 to 20% cases of Kala Azar, there is a residual, or you can say the inadequate treatment. The post-Kala Azar dermal leishmaniasis developed, which is a skin sickle, and it is characterized by skin rashes and tends to appear 2 to 3 years after the treatment of Kala Azar caused by Leishmania donovani. And it is endemic in an area of Bihar, Jharkhand, and some part of West Bengal and Orissa, and its estimated prevalence is ranging from 4.4 to 7.8 per 10,000. So there are 3 drugs available to treat this condition: miltefosine, sodium stevogluconate, and liposomal amphotericin B. But the miltefosine is the only oral drug which is highly effective against PKDL, and its recommended doses are 100 milligram per day for 84 days. Now this is considered as a safe drug with few adverse reaction like gastrointestinal symptoms, and there are few reports from India and Bangladesh who have reported some ocular complication in these cases. But the clinical impression in all these studies varied from Murren's ulcer to scleritis. There was no consistent feature among all the studies, and the clinical feature of keratitis, its course and management has not been established. So this paper was done to discuss the diagnostic clinical features, its progression, and the management in 6 consecutive PKDL patients treated in a single center. So this study was retrospective, conducted between April 2018 to December 2020, and which 6 PKDL patients were recruited who were receiving miltefosine. Studies was approved by IEC, and consent was taken from all the patients. In evaluation, we included the complete medical history, focusing on the drugs used to treat Kala Azar and PKDL. We have documented the dose and duration of treatment and the onset of keratitis after initiation of the drugs, and the detail of other drugs used for ocular complaints were also mentioned. We also did the casualty assessment of adverse drug reaction to miltefosine by WHO UMC criteria. So in workup for keratitis, we included the size, location, pattern, depth and extent of stomal infiltrates, extent of edema, presence or absence of corneal edema or hypopyon or any epithelial defect. We did microbiological evaluation of all the corneal samples, direct smear examination and culture. PCR was also done to rule out any presence of Leishmania donovani. RK39 and skin biopsy tests were done to check whether the disease is active or now it's completely healed. So in results, we found first case was bilateral keratitis, and he was a 31-year-old male. He was taking this drug for 48 days, and after appearance of ocular symptoms, he continued this drug for another 17 days. And at the time of presentation, we found that there was a paracentral dense full thickness infiltrate present in both the eyes, rapidly progressive and involving in the center of the cornea. And there was a thinning in the right eye, so we performed PK in this eye. This was a first case. We were really unaware of the condition and how to treat. We were not aware of this. So we started all topical antibiotics and sent the sample for micro examination. When the test came negative, we started oral steroid, and since there was a thinning, we started doxycycline also. In left eye, we started topical as well as oral, and both the eyes resolved very well after the use of a steroid, but it took a very long time, 5 months. Second case was also bilateral with very typical presentation of this drug complication, paracentral, full thickness infiltrate involving the whole circumference as well as the deeper area, giving the impression of annular ulcer or ulcerative keratitis. So in right eye, we did PK in view of thinning in the periphery, and left eye was responded very well to oral and topical steroid along with antibiotics in 4.5 months. Rest 4 cases had a common feature, like they were all unilateral, and they were also on miltefosine. They stopped the therapy after appearance of ocular symptoms, and they were all resolved with the use of topical steroid and antibiotics. We didn't use oral steroid in these cases. So overall, the results were ocular symptoms were common in all the patients: pain, watering, photophobia, and diminution of vision. And there was ring-shaped keratitis, full thickness paralimbal infiltrate, which was common in all with the hypopyon and edema. 2 cases had bilateral keratitis, 4 cases had unilateral. Laboratory test, smear culture, PCR were negative for the organism or any other microorganism, but RK39 and skin biopsy were positive, which says that the disease was active and the parasite was still in the skin. So management was common in all the patient. Discontinuation of metformin and initiation of corticosteroid were the mainstay of treatment, and casualty assessment showed that this can be a probable association of adverse reaction to miltefosine. So we found a consistent pattern of keratitis in all the case along with clinical course. So we could divide this keratitis into 2 groups. One is the early stage and second is advanced stage. In early stage, there was annular keratitis with intervening clear area from limbus and the infiltrate. In advanced stages, the infiltrate extended both centripetally and circumferentially and involving a look like ulcerative keratitis. As far as mechanism is concerned, it is not very clear, but some studies have hypothesized that drug might be very toxic to the ocular tissue because of its long elimination half-life, or it could be autoimmune reaction because it responded very well to steroid. So the management were common in all the cases, and by stopping the miltefosine immediately and excluding the infectious etiology, initiation of early anti-inflammatory therapy in form of steroids, and differing PK for the complicated cases, because both the in cases where we didn't do any surgical intervention, that those cases performed really well. So we have emphasized the need of strengthen the pharmacovigilance program in endemic areas for ocular examination in the patients who were taking miltefosine, and its course, like early diagnosis and discontinuation of therapy is really important. So we published this paper in BGO, British Journal of Ophthalmology, and after that, in 10th February 2022, WHO took this case very seriously, and they published some result that the periodic ocular examination should be done in all the patients who are taking miltefosine for this condition. And after that, they made a multidisciplinary technical group, and I was also an observer in that group. And after that, very recently in 12th April 2023, they published the whole report with some annexures on tables that how to follow up these cases and what to be done if something happened to the eye. So and they give information to all healthcare workers, to patient, and they also emphasized the strict active surveillance in these cases in endemic areas. Thank you so much.
Lovely presentation. It is really enlightening, and it was interesting to see that miltefosine has been described as a treatment for
Acanthamoeba keratitis,
and
right?
infiltrate also looks like a ring infiltrate, just like acanthamoeba.
Yes.
So it's very good information for. I didn't know that it could cause this complication.
Thank you, sir.
Thank you.
Thank you so much, Rakhi. Seriously, a beautiful presentation. Have you otherwise used miltefosine for any patients with acanthamoeba or?
No, not yet.
Thank you.
After this, I think I'm not going to use it.
Yeah, because there are papers being published
Yeah,
for.
there are some papers with multifossinic acanthamiba keratitis, but some has shown worsening also. Like one from LVPI, they are doing some pilots study of topical multifossin in acanthamiba keratitis, and they stopped it because of the worsening of keratitis in all 5 cases. So probably I'm not sure whether it is working or not, and still we are not clear whether this organism present in cornea or these are the sidal effect. We still not sure.
Thank you so much, Dr.